This is a patient who's had a previous vitrectomy for macula surgery. She has a dislocated crystalens bag complex and is here for us to remove and replace this with Yamane intrascleral haptic fixation. I've placed my trocars and this is a 275 incision. I'm going to flare internally a bit to get this lens bag complex out. I'm doing a little vitrectomy behind the lens as there still may be some vitreous present. And now I'm going to push the lens forward as I grab it with a micro forceps and rock it above the iris here. You can see this giant Sommering's ring. And I want to manipulate this whole lens bag complex with the Sommering's ring in front of the iris. And I'm going to sort of hand over hand this to myself and pull this forward. Here, there's a thick fibrotic anterior capsule over the haptic plate here. I'm going to grab this and pull this forward. And as I manipulate this lens, I want you to watch how the haptics, which are made of polyamide, they become so fragile they just break right off. And you have to be very careful not to lose these sharp fragments in the posterior segment. So now I've shut my infusion off and placed viscoelastic above the lens, and I will cut the lens bag complex with the infusion off. I'm cutting diagonally so I can get the lens out in two pieces. And I'm going to pull the sharp edge of the optic out first so that the trailing edge, the plate will come out behind it. And when I do this, you'll see these little haptics snap off, and I don't want to lose those. I'm going to keep my eye on those. Now I'm going to try to rotate this so that I can grab the pointy end of the optic and pull this out from that side, but the lens won't rotate. And I'm trying to rotate it, but just simply when I try to rotate it, it just snaps right back. So I'm fussing with this, and then I realize there's probably some zonules here attached to the Sommering's ring bag complex that are holding it, and that's the case. I'm going to cut these with the vitrector using the posterior approach here. Once I've done this, now the lens will rotate so I can grab it by this edge of the optic and pull it out through my incision. And look at that haptic breaking off. So I want to make sure I get all these haptic fragments out. They don't fall back. So that's going to be my strategy to make sure I don't lose any of those. Watch those as I pull this out. There's the other one right there coming out. And now I've got to get the Sommering's ring out. I'll position it so that the Sommering's ring is pointing out through the incision, and I can then guide these pieces out with infusion on and sort of stuffing it into the incision with my Sinskey hook with the infusion on so I don't lose these pieces posteriorly, because they can be calcified and kind of sharp and hard to get out. So now I'm going to go ahead and complete my vitrectomy. Now, even though this patient has a previous vitrectomy by retina, there's still plenty of peripheral vitreous left, as you can see here. If I'm going to do Yamane, I want to make sure I don't pass needles through that vitreous. I'm also removing any small pieces or fragments of lens material that may have fallen back. Here I've got the infusion off. I put viscoelastic over the optic to block the incision. I turn the infusion back on and I make my first needle pass. I put the distal haptic in this needle. I'm going to put the haptic in the eye. You'll notice the infusion is on to firm up the eye to a standard pressure 25 so that my needle passes are uniform and always the same. I'm going to push the lens away from me, grab the haptic and push this haptic into the 30 gauge needle, and it just guides right in very nicely. Now I will simultaneously rotate the lens as I pull both needles out of the eye and extricate the haptics. I melt the first flange here and push it in. You can see it's a very tight fit in the sclera. That will keep these haptics from extruding. I push the flanges all the way into their tunnels and make sure tenons and conj move freely over the flanges, which will again keep the haptics from extruding. Viscoelastic is removed from the anterior chamber. Myocol is put in to constrict the pupil. I make an iridotomy at 6 o'clock with the vitrector to prevent reverse pupillary block in every case. Here I'm placing 2 limbo-relaxing incisions to reduce the patient's with the rule astigmatism. These are on the 120-degree axis as per my surgical plan. I'm also going to place a suture in the main incision to prevent any astigmatic component from the incision. Here you can see I'm going to tie this, cut it, and rotate the knot into the corneal stroma. And this is really for astigmatic purposes, not for wound closure. I remove the trocars, and as I do this, I cauterize the sclerotomies to prevent leakage, and the case is completed. Thank you for your attention to this case.